And so now here, what I did, so cataract, okay, we do everybody is doing cataract, and how I have ensured the safety in the high volume cataract surgery. So that I am presenting here, and so this is the outcome of the high volume cataract surgery. So we have done the near about. See, this is our tribal in the Melghat, that is Amravati, Gadchiroli, and the Nandurbar. So these are tribal people, so they will not come to any clinic anywhere. Maybe bilateral, maybe unilateral mature cataract. They will wait. If the doctor goes there, then only they will come to the doctor, and then they will get treated. So, and this is the queue in the tribal area. This is near about 1 kilometer queue where the patients are coming for the examination and then for the treatment. Every year, this is from 26 years we are doing this. And then the high volume cataract surgery, we always discuss we should do it or we should not do it. So that is what the pitfalls. And then when we are doing the see the we must reach such people. We thought, and I thought it, we should do it, and everyone can't come to you. And then what we can do is we can reach to them, and when they reach to them, then in the camp. So in the camp, we have not operated in any other, but only in the camp, high volume camp. There, the quality should not be compromised for a single patient because the eye is very important. And that we do create and can see the protocols and operation theatre, and that I am going to just see. Operation theatre, we have operated only in the ophthalmic theatre. So there are 70 ophthalmic theatre in Maharashtra, and in that we have operated, and it is a regular theatre. Every day this theatre is used. But when we go for this, then generally when in medical colleges and civil hospitals and the ophthalmic hospitals we operate, and the operation theatre sterility we maintain, though it is maintained every day. We do the 3 swabs of this theatre also, and 8 days before, also the air shuttle plate, and also the swabs of even the wall also. And those swabs are sent, and not only for the anaerobic bacteria, but also the culture and sensitivity. And if those are negative, then only we go and then we operate there. So surgical equipment also, we take all the equipments with us. It means all type of, and this is the truckload we're taking from the Mumbai to the Gadchiroli and to the Amravati, and also the Baba Amte, that is a leprosy ashram there. So we operate there, and we take all the equipments and disposables with us. So we screen the patient. Every patient is screened for the ophthalmological diseases, operable cataracts. It means we choose the bilateral mature first, mature, and later on the mature. So treatable these cases, and we always see that the patients are the, can say, see, this is what each patient is examined, and once this patient is examined, you will see these are all the leprosy patients, these are tribal patients, these are operated patients sitting. So we examine, and then the patient admission and identification. Every patient is admitted, the name of the patient, you can see there is a name, then what is the diagnosis, then what is the systemic disease, and IOL power is behind this identity card. So this is what is the worksheet of each patient. We operated 1,19,000 patients. We have got the worksheet. You can see the lens sticker also after the surgery. The sticker of the lens is also there. Post-operatively, we examine the patient twice. That is on the 7th day, on 30th day. We give them the spectacle, that is also free, because that is not, they are not affordable at all. So if such type of patient come with the mature cataract, we give them the treatment for 5 days, and as those are mature cataract, we operate them on this one. We separate out such type of patient. It is called as the last in OT. It means those patients need surgery, but they will not going to come for a year, and then there will be lens-induced glaucoma. So we operate them last, and then kept in the isolated ward, and then antibiotics prophylaxis, and then we operate the last in the operation theatre. So those instruments which are used for such cases are not used there unless and until those are sterilized. The preoperative and intraoperative, you can see these are the leprosy patient. We clean their feet also, and after that you will see the leggings. So every patient is having the leggings, and then we operate the patient. The two tables for the residents alternate, and then for the teachers. Then this is the autoclave. This is the autoclave everywhere. Instead, without that, we never operate the patients. And operating sets for each table, we have got the 10 sets. We take 10 sets and we go. It means if we are using the 5 tables, then 50 sets will be there or 60 sets will be there. The consumables in the OT, so these OT consumables we are disposable. These consumables from 1999, we have never reused this till date. So and this is what post-operatively every patient is instructed by myself or Dr. Raghunath. We instruct the patient and what is to be done in their language. It is very important. And you can see the post-operative examination. These are the patients, they don't know who is operating. They only know that person from Mumbai and one female and male is coming and they are operating. That is what only they know. So nothing, they don't know anything. But second day, they put their hands on you can say the cheek and the so rough hands, but the love behind that is like that, so much hard love. So that blesses us every camp. So we do 6 camps like that, and we give the post-operative instructions in such a huge mob there. We have done till date the 693 such type of camps. Out of that, the 128 pickup, 192 were the operative camps. We operated 1,19,000 cases for each, and these all cases are pre-op cost we have done. And we have got end ophthalmology. It's not like that it has not got. But every patient was brought to the center and we operated them. And every patient we tried to give them vision in these cases. And you can see, always ask to me, why you can operate so many cases, why you are working for 18 hours. But the second day, smile on the face of these blind people, they help me every day and inspire me to operate. And this is me with the patients. This is in the Gadchiroli, we are there. And there, can say, we treat these all patients like, can say, OT list also. Then, we have got the team. Those are not doctors, 11 teams. So they come with us, and every team is different. It means feeding team, the fitting team, bringing team, going team, dilating team, every team is different. They are advocates, they are also IS officer, IPS officers, everybody, the big people, they come in the camp and operate for 5, they stay there, work for 5 days, and then they go back. That is what we do here. The second thing is now why I started this. This is my mother. She gave me her kidney in 1995. So now I have completed 30 years of my kidney transplant, and my mother just now she left me in the July. And because when she gave the kidney, she told the doctor that remove one kidney. If that is not fitting to my son, give another kidney, but my son should survive. I thought my mother, who is illiterate, she says that my son should survive. On that day I decided this is my second birth and I should work for the poor people. And from that day onward, 30 years, I'm working for the people who are really needy people. And how I started, I want to say that hard work. I was a laborer for 10 years. Then I learned myself. I was just, you can say, watering the plant. This was earned while learned. I was getting 30 rupees in the 11th and 12th. Before that, I was a laborer getting 1 rupee. And then I got the kidney transplant and transferred myself. And you will see the 2008, without any application, I got the Padmashree because I operated 1 lakh surgeries that time. The second thing is I rose to the dean, then the medical director. So I want to say that hard work, problems always come, but hard work you definitely succeed. And I made a Doctor Protection Act. One doctor was vandalized, his hospital vandalized by the politicians. We went on strike. 2010, I was a leader. And we made first Doctor Protection Act in Maharashtra for the doctors. You'll see the problem of the cashless is going on. Mumbai is not practicing cashless from 16 years. And because of that, we send it to the reimbursement. And now we have come to the conclusion they are now compromising with us, where now they will allow us copay. It means if 30,000 insurance is going to give, they will permit us for another charges to the patient. And now I think we will solve in one or two, not only for Maharashtra, but all over India. Secondly, I will tell you there is no single consumer case in Mumbai from last 16 years. Why? Because one of the doctors said that lens inside the eye is ulta, opposite. And because of that, he have got the glaucoma. That patient went in court of law. In this such type of forum, I called that doctor on the dais and asked, now we should give him Nobel Prize because lens opposite can give -2, never give the glaucoma. You tell me where is the research, where is the publication, or otherwise ask that patient to take that case back. And when I asked him in front of the 700 doctors, he told that patient and the case was taken back. From that day, not a single doctor in Mumbai criticizes the other doctor. You see the IS officer, IPS officer, they never criticize, but we criticize each other. We are a soft target. We are a soft target. So I think anybody will not spoil anybody's eye. That is a surgical skill. So we must say that he has done the good. He has done the good. And if you say that, nobody will go in court of law. That is what I feel. And for that, I request if you can help me for Vice President AIOS. Thank you very much. Thank you. Thank you.
Thank you very much, sir. And sir, you can join us here on the dais, sir. I'll ask Dr. Ratish Pal, who also does a huge number of charitable cases in this part of India, to give a comment on Professor LAHANE's.
Sir, Professor LAHANE, sir, you are an living eye hero. Living eye hero. We must all endorse from this meeting. Definitely, sir, what you are doing a commendable job, and you are most respected. We have no hesitation bowing down in front of you, every one of us, for your this tremendous job, sir. Thank you, sir.
Thank you very much. Now comes the Dr. Shubhan Bhattacharya. So Shubhan is going to tell us all the problems of the BHEX. Is that so, Shubhan?
Yes.